Good day. Welcome to our ISE proposal presentation. This part will discuss about candidate Y and Z. We hereby do propose our product, adagrasib, which is the combination of nab-paclitaxel and atezolizumab. Patients with triple-negative breast cancer express programmed death ligand 1, PD-L1, mainly on tumor-infiltrating immune cells, and it can inhibit anti-cancer immune response. Thus, an anti-PD-L1 agent, atezolizumab, was selected as our candidate Z. In this case, nab-paclitaxel was chosen as the partner for atezolizumab. This is because taxanes have synergistic effect in activating toll-like receptor activity and dendritic cell activity. Atezolizumab will then disrupt the engagement of PD-L1 with its receptor and hence activate cytotoxic T lymphocytes, thus inducing apoptosis. Besides, previous research also suggested that this combination therapy had clinical benefits. Here is the summary of pharmacokinetic characteristics for atezolizumab and nab-paclitaxel, which including their distribution, metabolism, and excretion. Now, let's focus on the formulation of paclitaxel. Why nab-paclitaxel is preferred over than standard paclitaxel formulations? This is because albumin-bound nanoparticle formulations enhance the transportation of paclitaxel, thus increasing the tissue penetrations. With this, nab-paclitaxel offers better survival rate. Moreover, nab-paclitaxel is formulated without the solvent, and it does not require glucocorticoid premedications to prevent hypersensitivity reactions. For the clinical evidence, the combination therapy increased objective response, disease control, quality-adjusted life years, progression-free survival, and overall survival. This part will describe about the marketing strategies of our product. It has been reported that almost 200,000 triple-negative breast cancer cases are diagnosed each year. Increasing prevalence of triple-negative breast cancers has driven the growth of the treatment market. In the next 10 years, the triple-negative breast cancer market will experience rapid growth across the United States, Japan, France, Germany, Italy, Spain, and the United Kingdom. The market is forecasted to value over $820 million by 2027. Atezolizumab in combination with nab-paclitaxel is indicated for the treatment of adult patients with unresectable locally advanced or metastatic triple-negative breast cancer whose tumors express programmed death ligand 1. This combination therapy significantly improves progression-free survival with a 40% reduced risk of disease progression or death. The 1-year progression-free survival was 29% with atezolizumab and nab-paclitaxel. Besides, the median overall survival was 21.3 months with atezolizumab and nab-paclitaxel. Additionally, the combination of atezolizumab plus nab-paclitaxel has manageable safety profile and allows the patients to have a reasonably good quality of life. The dosage regimen is summarized in the table. Each cycle consists of 28 days. Atezolizumab is administered intravenously on day 1 and day 15, while nab-paclitaxel is administered intravenously on day 1, day 8, and day 15. These treatments target at least 6 cycles administered and with no maximum treatment cycles in the absence of disease progression, unacceptable toxicity, or withdrawal of patient consent. The estimated cost per each cycle will incur around $8,036. A cost-effectiveness analysis has demonstrated that atezolizumab plus nab-paclitaxel as compared to nab-paclitaxel monotherapy resulted in an incremental cost-effectiveness ratio of 183,000
$201,508 per quality adjusted life year. Considering willingness to pay threshold of $200,000 per quality adjusted life year, this combination therapy was likely to be a cost-effective treatment. Next, the drug interactions for nab-paclitaxel and atezolizumab are summarized in the tables.
Now, let us move to the SWOT analysis. Firstly, strengths of this combination therapy includes higher anti-tumor response rate, prolonged progression-free survival, and overall survival, besides having manageable side effects, which has shown by previous studies. Secondly, weakness of this combination therapy is the targeted patient population may be limited to patients with PD-L1 positive, recurrent, or metastatic TNBC only. Moreover, high costs incurred by the treatment for stable disease and disease progression. Thirdly, opportunities of this combination therapy includes expected increases in demand and market because of the poor prognosis of TNBC. This combination therapy also has the potential for development as the first-line therapy for unresectable locally advanced or metastatic TNBC expressing PD-L1 in all countries. Lastly, the threats of this combination therapy is significant competition from other established targeted therapies. Marketing goals are listed below. First, promote our product and increase product awareness. Second, boost awareness of disease states and emerging treatment options that are currently available. Third, reach healthcare practitioners, patients, and caregivers to provide them with the information about our product. Fourth, increase market share. Fifth, increase company profile. Sixth, try to build brand loyalty while remaining within the code of ethics. The first step of STP is market segmentation. We divide the market of potential customers into segments based on characteristics. First, patients, which segmented according to treatment-naive metastatic TNBC patients who expressing PD-L1 and 18 years old or older patients. Next, physicians, which segmented according to specialty such as oncologists who specialize in TNBC. We systematically choose the segments that will allow us to achieve our goals most effectively. Our company has targeted some specific populations. The key target group can be characterized as follows: specialized prescribers, opinion leaders and cancer centers, patients, and payers. Since our company is a traditional powerhouse in the field of TNBC drugs, hence we have positioned our brand as the market leader of TNBC drugs widely, providing safe, effective, and high-quality TNBC drugs. Our company positions the product at the level of enterprise by introducing the latest achievements of our combined therapy. Also, our company developed corporate identity and packaging, which allows the healthcare practitioners and consumers to easily identify our product. Besides, our product is positioned with the allocation of the competitive advantages of drugs to distinguish them from competitors. In this case, our unique selling point is the combination of chemotherapy and immunotherapy that complement each other to produce the synergistic effects. This creation better meets consumers' demand and offers an alternative for TNBC patients.
Our first marketing strategy is digital marketing, where we utilize technology-based services to give the healthcare professional an insight regarding the clinical data on the effectiveness and side effect of our product. In such marketing strategy, we employ search engine optimization by using the keywords such as atazolizumab, nab-paclitaxel, and adaxel to boost our company visibilities. For patient-centered marketing, we prioritize the impact of our product to patient life. Additionally, we offer continuous medical education such as organizing conferences to introduce our product to the physician, which could influence their prescribing behavior. Adaxel, the key of your survival, is the slogan of our product.
This part will explain the risk management plan.
This risk management plan is dedicated to healthcare professionals. Overall, the combination of atazolizumab and nab-paclitaxel have manageable safety profile. Nab-paclitaxel is contraindicated if the liver enzyme AST is 10 times higher than the upper limit normal, or bilirubin is 5 times higher than the upper limit normal. Whereas atazolizumab is contraindicated if the patient had previous autoimmune diseases. One of the most common side effects was neutropenia, accounting for 70%. Neutropenia was positively correlated with increasing age. 46% of patients experienced nausea and 26% vomited. Female, elderly, and alcohol consumptions are the major risk factors for nausea and vomiting. Hypersensitivity reaction was seen in 20% of patients, and the most commonly manifested symptom was rash. Patients with history of hypersensitivity reaction and autoimmune diseases have a higher risk of developing hypersensitivity.
There are several proactive preventive strategies for each potential safety-related risk. Neutropenia can be managed by giving granulocyte colony-stimulating factor (GCSF). For example, filgrastim 5 mg per kg per day can be given starting 24 hours after chemotherapy and continue until neutrophil count has normalized. If febrile neutropenia occurs in the patient, chemotherapy should be withheld until fever resolves and the neutrophil count back to normal level. Empirical broad-spectrum antibiotics such as IV meropenem 1 gram every 8 hours should be initiated. Furthermore, paracetamol 1 gram can be given 3 times daily to alleviate the fever. To measure the effectiveness, neutrophil count and infection parameters such as body temperature and white blood cell count should be monitored. Adaxel has low imitogenic potential and hence tablet metoclopramide 10 to 20 mg can be given 30 to 60 minutes prior to the start of chemotherapy. It can also be prescribed every 4 to 6 hours when necessary for 3 to 4 days after chemotherapy. However, no prophylaxis given is acceptable based on the doctor's evaluation and judgment. For the non-pharmacological management, the patient can drink plenty of water, eat light and bland foods, avoid greasy foods, eat slowly, and eat smaller, more frequent meals to prevent or alleviate the symptoms of nausea and vomiting. To measure the effectiveness, frequency of nausea and vomiting, and severity of illness should be monitored. Antihistamines such as IV chlorpheniramine 10 mg and corticosteroids such as IV hydrocortisone 100 mg can be given to treat hypersensitivity reactions. The infusion rate should be checked from time to time as well. Stop the infusion if the patients develop hypersensitivity reactions. The infusion may be restarted at half of the infusion rate only after the symptoms have resolved. Rechallenge is strongly not recommended in patients who have severe reactions. To measure the effectiveness, signs and symptoms of allergy including rash, flushing, and hypertension should be monitored in patients. With this, we end our presentation here. Thank you for your attention.